Hi, everyone. Welcome to another episode of Enjoy the Life You're Living. I'm Jana Rieger, and I'm so excited today to have our guest, Taylor Kae Hahn. Welcome, Taylor.
Thanks, Jana.
So you're in your scrubs, you're in a medical facility right now, and but before we hop into all that, I'd love to start with your personal story, Taylor, and what motivated you to get into the profession that you're in, which is a speech language pathologist. And why don't we just start there?
Yeah. So when I graduated high school, I knew that I wanted to work with individuals with disabilities, but I wasn't sure in what capacity. Me and my friend, we worked together. We taught little classes to people who were 18 to 24, and I knew that I love working with that population. So I was like, okay, I want to figure out what more I can do on a professional level. And so I took a career exploration course, and that led me to they did um, personality tests and all kinds of things that led me to speech language pathology. And initially, I thought I was going to work with individuals with autism, but
Yeah,
an extremely challenging and difficult internship showed me that that was not the right fit for me.
right.
So every speech language pathologist in the US at least gets an adult placement or a couple adult placements and a couple of peds placements. And so when I got to one of my adult placements, I got into a hospital internship, which this was just following my grandmother's passing from complications related to a heart surgery.
Hmm.
And so when I got in this setting and with my supervisor, I just knew that this was the right fit for me. It shifted
Hmm.
that passion to the adult population and adult care. And I got to witness dysphagia management firsthand. And
Hmm.
I realized how much of an impact SLPs really have. They are pretty much the only ones managing, swallowing in a lot of these settings. And so, inspired by pioneers in our field like Dr. Susan Langmore and Dr.
Hmm.
Ionessa Humbert, I deepened my dysphagia expertise. And then, most recently, I took a course by Dr. Roxanne Diaz Gross to explore what's called the Diaz technique, which is called the dysphagia intervention for the esophageal zone, and that has really helped me focus my passion towards that more like pharyngo esophageal dysphagia management for people.
Cool. So maybe just for our listeners who might not be familiar with dysphagia, just like brief, what is dysphagia and who does it affect?
Yeah. So dysphagia is a short or the medical term for swallowing issues. It can be related to stuff happening with the mouth, chewing, even just with the tongue propelling food back. It can be in the throat. So, an airway management issue, whether the muscles in the throat are not working correctly or the timing of the breathing and swallowing may be off. And then this new course really opened my eyes to the importance of speech language pathologists in managing esophageal dysphagia. So, screening methods on what's happening once it gets through that upper sphincter at the base of the throat and into the esophagus, and how we can impact propelling food and liquids through that esophagus into the stomach.
Nice. Okay. And so you're in a hospital, so a lot of the when you're finding this love for it, so a lot of the patients you're seeing probably have had some sort of like big medical complication, whether that's like a stroke or brain injury or something like that. But are there other people who have a swallowing disorder that might not be related to such a, say, a traumatic medical event?
Yeah, absolutely. I've definitely seen more frequently now, and I would say maybe I think I looked it up, maybe 4 to 5% of people at some point in their lives will experience like a swallowing problem, especially with the globus sensation. And it's just related to, changes in breathing and swallowing. So a lot of times it's people with COPD may
Hmm.
present with swallowing issues, not related to anything that other than maybe their breathing. You know, uh, respiration cycles and
Hmm.
swallowing. Um, it could even be anxiety related. So there are people out there who will have maybe a one-time choking event that results in kind of like this overcompensation that
Mm,
prevents them from swallowing. And that's very rare, but it's becoming a lot more frequent.
mhm,
And I would say aging is probably the number one
mm,
dysphagia related impairment that isn't related to like a traumatic event. A
mm,
lot of people at some point in their lives will just experience swallowing problems because the muscles eventually just weaken over time.
mhm, mhm. Interesting. So you said a word that I've heard, but I bet other people might not have heard, and that was globus. So can you talk about what is globus?
Yeah, so globus sensation is the feeling like of a lump, tightness, or discomfort in the throat without
Mm,
an actual physical obstruction. So things are still going through, but they feel it somewhere on this continuum, whether they think it's up here by like the chin or near an Adam's apple, or most commonly at the where your sternum is and your clavicles meet is the biggest indicator of kind of a globus sensation where things are stuck in the esophagus. A lot of people will describe it as a stuck feeling in the throat. Um,
mm,
and it can be associated with stress, reflux. That's another really common diagnosis that results in swallowing problems is persistent reflux causing kind of like the acid and things to affect the upper throat and even the vocal cords in some extreme cases. Um, Muscle tension from either anxiety, stress, or some sort of like impairment of the spine or neck. And esophageal dysmotility, which can be related to a lot of things. GERD is one, but a lot of people will just have esophageal dysmotility because of hereditary things. So
mm.
here a lot of times people will be like, well, my grandma used to get her throat stretched like every year, and now I'm starting to have that issue, and I have to go to the GI doctor and have my throat stretched every couple of years. So
Yeah,
can be related to a lot of different things and can be very distressing if you don't know the source and the reason why it's happening.
right. So people are feeling like, okay, I've got something stuck there. It's not going away. So they go to the doctor. What kind of test would the doctor do to see if, like, do they have something stuck there?
Yeah, absolutely. So, a couple of different tests a doctor might order could be a modified barium swallow study or a video fluoroscopic swallow study. So it's MBSS, VFSS. That's a very complex study done with a speech language pathologist, and a lot of times a radiologist is present, where we look at the upper throat. And some speech language pathologists will screen at the front and look for esophageal propulsion. Another really common test that I recommend a lot of times if the swallowing appears normal is called an esophagram. Um, some places refer to it as like a cookie swallow or something like that,
Mm,
where they are just focusing on the esophagus and they'll do thin and slightly thicker liquids while somebody's laying down on a table and watch how their body propels that liquid and kind of thicker consistency through. Sometimes they'll even test a pill, and the pills are standardized in the radiology office for actually like the correct size of the opening of what they call the lumen or the those sphincters. So
mm,
everybody should open at least to the size of this pill.
mm,
See how it goes through and if there's any spots where it gets caught. Um, and then more advanced than that, they can refer to a gastroenterologist and they could do or not esophagram, a an EGD. It's a long word. I'm not even going to
mm,
split down, but it's an endoscopy procedure where you're asleep and they go in and they look at the structures in the esophagus. Sometimes they take biopsies. Sometimes if they find a stricture, they'll stretch any areas that appear tight. And so those are the three most common studies that they'll do to test for that.
yeah. So when someone has globus and then they get one of these tests, um, what usually would a doctor see? Is there really going to be a problem or is it just a sensation?
It really depends, and this is exactly why it's so important to have a knowledgeable clinician on your case, because a lot of times the diagnosis for globus sensation is exclusionary.
Mm,
So there's not one thing that says, you're going to have this issue. it could be related to a number of issues, and you have to rule out a bunch of different ones.
Mm.
So, one, it could be that stricture. So, if there's a physical like tightness in the throat, and they can stretch that, and that sometimes resolves that issue, that's a quick solution for some of those patients. Other times they do all this testing and they don't find anything but reflux, which reflux in and of itself can cause globus,
Mm.
but doesn't always resolve their issues when they start taking the medication for reflux. And a lot of
Mm.
people don't even want to take the medicine long term because there are risks and benefits to taking some medications long term, and
Yeah.
reflux medicines are one of those.
Yeah. So then you mentioned the Diaz technique, which I'm really excited to learn more about. When does that come into play?
So, Dr. Gross has a she long list of things that she wants us to look for first and rule out, which is to do an instrumental of some type, whether it be that modified barium swallow study or even an esophagram, because
Mm.
in a lot of cases, they're going to screen for aspiration and things in that esophagram too, to give us an idea as to what the structure and the physiology of the actual swallowing mechanism looks like. Um, and a lot of time we just want something to basically say, there's whether there is or is not some sort of physiologic reason
Right.
for the globus sensation.
Yeah.
If there is none, then we proceed with the Diaz technique. If
Yeah.
they find something, then we pursue the treatment options for that finding. And then if that still does not work, then we pursue the Diaz technique,
Right.
which it is a respiratory based therapeutic maneuver, and it's non invasive. So technically, the patients can start the Diaz technique and see if it works for them
Yeah.
while they're still pursuing those treatments if they do find something. So it's
Yeah.
not harmful to do the Diaz technique along with whatever treatment you're doing. So sometimes just making sure that it's not an issue up here that we can treat up in the throat or the pharynx or the airway closure is like the main basis to starting the technique.
Yeah. So it's interesting. So you're working with respiration or breathing, but it's a swallowing disorder. So how can you walk us through like what somebody who's sitting in front of you what would you be doing with them, Taylor?
Yeah, so the DS technique is based on the principle that swallowing with higher lung volumes and following that swallow up with a slow and steady exhalation can help improve the esophageal squeeze and
Hmm.
propel those foods and liquids through the esophagus.
So by
So
higher lung volume, you just mean like your lungs are more full with air? Okay.
correct. Yes, exactly. So we want the largest amount of air possible in the lungs. Basically, what happens is when we do that big deep breath and we bring air into our lungs, it actually changes the pressure in the esophagus.
Hmm.
So in the amount of air in your lungs, it causes, another pressure system. So they're kind of inverted. So if there's a lot of air in the lungs, you're going to get a negative pressure in the esophagus, helping pull stuff in
Hmm.
and kind of through to make sure it gets, to that middle part where we
Hmm.
have some deadening. There's there's not a whole lot of nerves right in the middle of the esophagus. And
Hmm.
then once it reaches that point, we want to do that slow exhale because we want to slowly increase that pressure in the
Hmm.
esophagus to push through and
Hmm.
get all of the bolus and the food and liquid into the stomach. And so the slow change in pressure, basically, you pull it in, you get that negative pressure, and then you switch it up and you get the positive pressure to push it through.
Yeah.
So when people are experiencing globus sensation, a lot of times it is in the middle of the esophagus where there's not a lot of, muscular control, but there are still sensory nerves.
Hmm.
And when we switch to inhalation or excuse me, if we switch to exhalation too early or inhalation too early, um, it can pause and prevent that squeeze from continuing. So
Hmm.
a lot of people will swallow when there's not a whole lot of air in their lungs. They get a little bit of an exhale, which starts that squeeze, and then they inhale, which it switches to negative. So it
Mm,
switches the pressure and it causes it to kind of press upon that area where the food is. And they can
right.
feel it then at
Yeah.
that point. And that's the highest level of discomfort when they get the lungs big again and there's still food stuck in that middle to lower section of the esophagus.
Interesting. So, when we eat, it's such a habitual thing. Like, you got your lovely burger or fries or whatever it is that you love to eat, and you're just stuffing it in. And you're in the habit of how that happens. You're not thinking about breathing. So, how do you teach people? Because it sounds like this could be a little more complicated than just eating. So, how do you teach people how to do that, Taylor?
So first, I was doing a lot of just focusing on, the respiratory cycle. So I was just teaching people what breathing feels like. And a lot of people
Mm.
don't do deep diaphragmatic breaths. And that's where breath kind of came in, where
Mm.
they had a visual on the screen while they were wearing the device, which gave them a tactile sensation, how long to breathe in, how long to exhale, whether it was the circle, you inhale on the up circle and then you exhale on the down circle, whether it was box breathing, where they were breathing in, hold, breathing out, hold. Both of those were really nice to demonstrate the what we would find the most ideal respiratory cycle for
Mm.
breathing. So then
Hmm.
once they had that like idea of how to breathe and how to get a nice big deep breath, I started them in the same cycle with breath. I had them breathe in, swallow at the top of the circle, and exhale to
Mm.
kind of incorporate that natural feeling of swallowing and breathing together so that they got it
Mm.
before we added any liquid or food or anything. We get it up here, we swallow, especially the box breathing was nice for that. So they inhale, and then where they would normally hold, they're doing a nice hard swallow because we want effortful swallows too. We still want those muscles to be
Yeah.
nice and strong. And then they would exhale on the down. And sometimes I would have them continue to exhale on that bottom of the square. If they still had air, I wanted a nice slow exhale. So I
Mm.
kind of used that nice visual that breath provides, along
Mm.
with the tactile sensation to kind of cue them when needed,
Mm.
to
Mm.
teach the ideal swallowing respiration um, cycle, like coordination cycle. And Dr. Gross talks about that in the presentation, that that's kind of what she did, but without all the fancy, technology, is that she just did diaphragmatic breathing exercises and then they practiced swallowing with the most air in your lungs that you could with the slow exhale afterwards. And then we went into like I went to liquids after that. So I would
Mhm.
use the box breathing because it gave a little bit more time for them to kind of swallow and respond, where they would put the liquid in their mouth, hold it,
Mhm.
breathe in because they had good control. I knew that they were not going to aspirate based on something sliding back. So they
Mhm.
held it in their mouth, breathe in, swallow the liquid, and then slowly exhale on those
Mhm.
other sides of the square. And
Mhm.
so we did that a good number of times, and I would watch them and look for that swallow, which at that time I was also using the mobility, but I wouldn't show them the mobility. I would have the mobility on them, and I was looking at it on my device, and I
Mm.
could then see if they had swallowed or not, just using the live,
Right.
kind of biofeedback thing. So I was like, I saw you breathe, but you swallowed first. The next time, I want you to
Um,
make sure you're breathing, then swallowing to make
yeah.
sure that they really got the idea of how this was supposed to work
Yeah.
and could start implementing it into everyday things. Then we
Yeah.
would move to the cracker. And I usually didn't do that with the box breathing because that was kind of hard to do.
Mhm.
But once they had really understood that
Mm.
concept of I got to breathe and swallow, we then brought in the food, which added
Mm.
another level and layer of complexity.
Mhm.
Because a lot of people, you can breathe and chew at the same time.
Right.
A lot of people are.
Yeah.
But what's happening is they're chewing, chewing, chewing. and they're breathing out a lot of the time,
Yeah.
and they're swallowing when they've got no air practically in the lungs.
Yeah.
So, not a whole lot of negative pressure happening in the esophagus to help pull things in. And then once they did get it down into the esophagus, because the muscles of the throat are going to propel it in, anyways, they were functional and working. Um, Once it got down to that middle part, they were breathing in at the wrong time because they got no air. So they had to breathe in.
Mm-hmm.
At that time, once that pressure switched to positive, then they could feel it. And they were like, oh, I did it wrong. And I said, yeah, I kind of watched you not breathe when you before you swallowed there. Um, so many people had the most difficulty coordinating that breathing and swallowing while they were chewing because they were more focused
Mm.
on the chewing part
Yeah.
than they were taking that good breath in. So it was a matter of, at that point, teaching them chew, 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 chew. Are you ready to swallow? Wait, hold it in your mouth, breathe in, big lungs. And the breath had taught them such good diaphragmatic breathing. They knew what it felt like to have nice big lungs. Do that hard swallow and slowly exhale to help that propulsion through. And I specifically had a gentleman who, when he first started, he was like, I don't know that I'll ever get this. And by like the third session, he was like, this is incredible, and it's honestly working for me. And I'm starting to use it every day. I practice it with my coffee in the morning. I practice it with my breakfast. And he was just shocked at how simple the maneuver was, but
Yeah.
how effective it was to help him in his own propulsion and
Yeah.
prevent that like kind of stuck feeling here, that discomfort that he experienced with every meal.
Yeah. Wow, interesting. And so, would you say that when you started talking to people about breathing, it almost sounds like a lot of them were out of touch with it?
Yes, absolutely. I would say even I sing in a women's barbershop chorus. I'm a sweet Adeline, and I
Nice.
would say even with singers who sing every single week, multiple times a week, sometimes struggle with the idea of concept of, that big, full lung and really getting a nice deep breath. So in our rehearsals, we do a lot of breathing coordination. And I
Mm.
would say that the typical person doesn't get that kind of exposure to like a respiratory cycle, and they're doing just shallow breathing and really benefit from learning and being taught about diaphragmatic breathing. It has so many benefits, and I tell people a lot of the time too, beyond that breathing and swallowing coordination. That in the presentation with Dr. Gross, she talks about how the Estel voice treatment utilizes the like a very similar concept to the Diaz technique to get rid of mucus in the throat. So like that post-nasal drip that we get, or like,
Mm.
the feeling of kind of like that sticky, yucky gunk,
Hmm.
to clear the throat and the airway, and then also to reduce nerves. So they're telling people, professional singers who and people with voice disorders, to utilize this big breath, hard swallow, slow exhale to not only get rid of stuff in here, but to regulate the nervous system.
Mm.
So we have to think, I think a lot about the vagus nerve and its impact and how it runs the gamut from, the throat all the way down to the lungs and into the diaphragm, and it really affects our tension in our body. And so
Mm.
diaphragmatic breathing has such a huge impact on everyone. So
Yeah.
I definitely recommend that any normal person could benefit from learning about diaphragmatic breathing and that cycle of breathing, swallowing.
Yeah, for sure. Well, of course, I'm a big fan of breath work and how it relates to all this. And it's interesting that I think there's a disconnect between breathing and swallowing, and that people don't realize that the two go together. Even our educational systems for training speech pathologists, um, were taught, I was taught anyhow, the background of breathing was really related to voice production, speech, but never did we learn breathing in terms of swallowing. So I love how you've explained it. It's so clear, Taylor, and so thank you for that. I've learned something really interesting today from you. Thank you.
Yeah, of course. And I agree. I remember in my graduate program, I had one dysphagia course through the whole
Yeah,
thing with
yeah,
I can't remember the professor, but it was a gentleman who was very, very knowledgeable and influential in some research about dysphagia. And I remember the most focus being on neonatal, where they suck, swallow, breathe.
yeah,
But never did we continue to explore what happens with that breathing cycle after we reach, beyond when once that, mechanism grows, what happens then? And nobody sits down and tells children, you have to breathe, swallow, slow exhale. No, I mean, sure, we get some cueing on chewing, chew with your mouth closed,
yeah. Don't
Um,
talk with your mouth full.
Right. But why is that, right? Because if you breathe in at the wrong time, you're likely to inhale that into your lungs. And so, it's not like specifically mentioned, but it's inherently gestured to and really should be explored more. And Dr. Gross is doing really great research, and she's done really great research on that coordination of breathing and swallowing over her, like, professional years, which is so great.
Yeah. And it kind of sounds like, as I'm imagining this in my mind when you're talking about how it works, I was like, well, it's interesting. You'd really have to slow down when you're eating and not just like stuff a meal in your mouth fast, right?
That's exactly what I tell my people, especially in the current, work environments. Most people aren't getting a long break when they're working. I work with a lot of nurses, and the nurses they're eating as fast as they can in the 20 minutes that they have to get it down. And so we get into these habits of just, we add more food, and we add more food as we swallow some of it, we add a little bit more. And so we get into this habit, these, things that are going to affect that breathing, swallowing coordination that we don't realize eventually may affect that propulsion in the esophagus as we get older.
Hmm.
And so it's a habit that you have to unlearn, because when you're healthy and normal and young, it doesn't really affect you. But once
Mhm.
you get in, especially to those advanced like ages, 70, 80, 90 years old, it becomes more important than ever to slow
Mhm.
down and to really focus on the ideal breathing and swallowing coordination to prevent aspiration and choking events.
Yeah, yeah. Can we talk a little bit about anxiety? Was that something that you would see in the people who you worked with who came to you?
Yes. So I had one in particular. She did have a choking incident and then ended up having a lot of anxiety. And I have fees available here in my office, actually, for my private practice. I do the fiber optic endoscopic evaluation of swallowing. And so I took a look, and I don't have stroboscopy, so I can't go in and really delve into the vocal mechanism and how the vocal folds are moving when compared to that breathing coordination, although I am trained to do it. But I can see when there's tension,
Mhm.
when they're voicing, you can see they'll maladaptively move muscles when they're breathing and swallowing and doing different things that are not normal. And so the breathing techniques honestly helpful to reduce some of this tension in here. We don't want all that extra tension up here either, because that can cause issues down below as well. It's all kind of connected. And so doing some breathing exercises before even eating helped remove some of that tension related to anxiety. I call it anticipatory anxiety when swallowing. And so that honestly was so helpful too, to show her that breathing and can really affect that like nervous system, calm it and reduce tension that is impacting the swallow as well.
Yeah, for sure. Um, so you've talked a little bit about a few different technologies. You use fees. I love fees. I think it's great. Um, you also mentioned breath and you mentioned mobility. So without getting too detailed into what all these things are, what do you think is the benefit of using technologies like this in a clinical practice?
Oh my gosh. Almost everybody that I talk to benefits from seeing what's happening with their body. They want some sort of like mind body connection.
Hmm.
Just swallowing, it's difficult to even modulate what's a regular, what's a hard swallow for a lot of
Hmm.
people. You
Hmm.
know, what might be my hard swallow could be that regular swallow for some people. They might be squeezing so hard every single time. Or in
Yeah.
the opposite, they're, even on a regular swallow, they're not reaching what we would consider to be ideal or like, enough squeeze to make that work. And so for swallowing, it's really nice to have like some visuals. So the mobility device that the oh my gosh, SEMG device, surface electromyography, is really nice so that they can kind of mind body connect the throat and the swallowing. The breath is the same thing. A lot of people don't necessarily breathe in long enough, or they
Hmm.
could add more and they don't.
Hmm.
And
Hmm.
so having that visual to get that nice full lungs with using
Hmm.
breath, and then having that tactile feedback to say, okay, now it's time to either hold or to exhale, was really nice for those patients. It truly, having biofeedback can be motivating for these patients to change, and they understand what they need to change by
Hmm.
seeing it and then being explained what's happening on the screen. So then you change it and you show them the difference, and then they can implement it without having the device. You do it
Right.
so many times with some sort of visual biofeedback. Then you take the biofeedback away and say, do it the right way now. Let's see if you can
Hmm.
carry this over. And a
Hmm.
lot of times they have way more carryover with
Hmm.
using the visual biofeedback than if I were to just tell them what they're supposed to be doing.
Right.
Like, what am I supposed to be doing with my body? I'm not like a gym person. I don't really do a whole lot of exercise, but I remember going to physical therapy and they're trying to teach me how to do squats, right? But the right way. My PT's like, well, your butt's tucking in, or you got, your thighs aren't far enough apart, and I'm like, oh, I just like I can't visualize it. I can't see myself. And so once you put me in
Yeah.
front of a mirror and
Yeah.
I could see her and me at the same time, what a big difference it was, because I could then visualize what's happening with my body
Yeah.
and carry it over. And wow, how empowering that is for patients to take control of their own bodies, to be able to then functionally make a change that matters in their everyday life that they'll use for the foreseeable future.
Yeah. Wow, that's exciting. Thanks for sharing that. So before we end, there's one question that I always ask all my guests, and that is, what does the phrase enjoy the life you're living mean to you?
Enjoy the life you're living. I think that that means embracing the present
Mm.
and finding that purpose and meaning in every moment. We get one life to live, we get one body to live it out in. And so, actively seeking the good and the best in that life that is, even during challenging time, difficult to see,
Mm.
it's is the purpose of that. When life is overwhelming, it's essential to shift your mindset, whether through meaningful connections, new experiences, or just changing your perspective to
Mm.
focus on those positive aspects and make the most of your journey.
Yeah. Well, thanks, Taylor. You certainly are, and you're an inspiration. And I'm just so excited to hear about this work that you're doing. I think it's so needed, and I'm excited for more people to learn about it.
Thank
So
you. Me
thank you
too.
again.